Hello, today's presentation is a pain overview and overview of the reasons why we would be required to rotate somebody from one opioid to another. This presentation was written by Chris Keogh and will be read to you today by Sam Morehouse. Pain is defined by the International Association for the Study of Pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Pain is a symptom feared by many. For patients who, at the end of life, it can be due to illness, treatment, debility, and comorbidities. Pain occurs in 50% of patients with advanced cancer and is a significant symptom for those with other non-malignant illnesses. Effective pain management requires appropriate clinical assessment to form a management plan. The aim of the assessment is to determine the cause of the pain, its nature and severity, effect the pain that has on the patient's lifestyle, and what helps and what doesn't help. Pain is a personal experience occurring when and where the patient says it does, and therefore pain is subjective and individualized. Its stimulus is physical and or mental in nature. It can interfere with personal relationships and it affects a person's quality of life. Pain perception and the pain experience are influenced by a number of factors, including the mental state of the resident, especially in a person with depression, anxiety, and delirium, past pain experiences, and other symptom issues such as nausea and or insomnia. Untreated pain is associated with poor health outcomes, and it affects a resident by decreasing their function, so reducing their ability to shower, toilet, and be independent, decreasing their quality of life, so they are unable to undertake activities or enjoy time with friends and family, anxiety and depression, sleep disturbances like being unable to sleep due to pain and waking often, falls, having reduced mobility and balance increases the incidence of falls, and social isolation, causing a resident to be withdrawn into themselves and unable to focus on other activities. Here we have an infographic on how to treat pain. We are going to go into this in a little bit more detail now. The mainstay of treatment is the use of analgesia. The choice of analgesia is usually based on the type and severity of the pain. Mild pain is usually managed using paracetamol or non-steroidal anti-inflammatories, the most common being ibuprofen or Nurofen. In palliative care, the use of a weak opioid such as codeine is limited in use due to a ceiling dose and its limits and escalation with paracetamol and ibuprofen and severe constipation being a side effect. Tramadol's adverse effects limit escalation of doses and potential drug interactions are an issue. Non-steroidal anti-inflammatories can be used for moderate pain that is due to inflammation and tissue injury, for example, metastatic bone pain. Opioids may be required for moderate to severe pain, the most common opioids in palliative care being morphine, oxycodone, fentanyl, and hydromorphone. In palliative care, it is usual to prescribe a breakthrough pain dose in addition to the regular opioid dose. Non-pharmacological interventions, such as the use of heat or cold, immobilization or massage may help to relieve the pain and are often used in conjunction with pharmacological management as well as adjuvant medications. The non-pharmacological interventions can be combined or used individually. Generally, the cause of any pain in palliative care is likely due to a combination of different mechanisms that respond to different analgesics. If a resident or patient has an element of neuropathic or nerve pain, adjuvants can be effective in assisting with that pain management. The most common of these are antiepileptics such as pregabalin and gabapentin, corticosteroids such as dexamethasone and prednisolone, antidepressants such as amitriptyline, nerve blocks or topical anesthetics such as ilignocaine patches can also be helpful in some instances. Now we're going to look at why we need to do opioid rotations in some instances. Opioid rotations may be required for the following reasons: in residents or patients with poor kidney function, impaired liver function, someone who is experiencing a rapid escalation in pain, someone who has a poor response to their current opioid, or to manage adverse effects of the current opioid they are taking. Sometimes the resident or patient will require a change of route of administration of their medication. The most common is from oral medication to subcutaneous medication. Often this is required at the end of life for a resident or patient who is now unable to swallow, but can often occur at other times. This can occur if the resident has difficulty swallowing medication, has severe nausea and vomiting, has a bowel obstruction, or has changes in cognition, for example, delirium or dementia. When considering rotation of an opioid, it is important to understand the mechanism of absorption of medication orally, called the first pass metabolism. This is the amount of drug that is lost during the process of oral absorption. After a medication is swallowed, it is absorbed by the digestive system and enters the hepatic portal system. It is carried through the portal vein into the liver before it reaches the rest of the body. The liver metabolizes many medications, sometimes to a large extent, meaning that only a small amount of the active medication emerges from the liver into the rest of the circulatory system. Therefore, in many cases, the first pass metabolism through the liver greatly reduces the concentration or availability of the medication in the body. Notable drugs that experience a significant first pass effect are morphine, diazepam, and midazolam. First pass metabolism only occurs with the use of oral medications, a medication that is swallowed and absorbed by the digestive system. It doesn't affect medications that are taken subcutaneously, transdermally, sublingually, intranasally, intrathecally, IV, or intramuscular. If you are rotating a resident from oral medication to subcutaneous medication, it is important to know that you will need to reduce the amount of medication to be given so as not to cause side effects such as opioid toxicity. We will not go into too much detail about drug calculations, but it is important to remember if you're rotating from an oral medication to a subcutaneous medication, the dose will be much smaller when giving the medication subcutaneously. This slide illustrates that converting someone from oral to subcut morphine is not equal or equivalent. Considering first pass metabolism due to absorption affecting the potency of the medication, it is recommended that when converting oral morphine to subcut morphine in stable pain, we divide the total daily dose by 3. The 5 basic rules of conversion are: add up the total amount of opioids that a resident has had in the last 24 hours. This includes both the long-acting opioid and the breakthrough medication. Usually you look at adding about only half of the breakthrough medication. Then, using the guidance document from Safer Care Victoria, Opioid Conversion Ratios Guidance, convert the total 24-hour dose to the oral morphine equivalent. Considering the first pass rule, we then do a dose reduction of 25 to 50%. Then you calculate the dose of medication that you are wanting to commence. Always remembering that you have the long-acting dose and then a breakthrough dose, which generally is a 1/6 to a 1/10 of the total daily dose. If you're wanting to commence a subcutaneous dose, then you need to remember to divide the number by 3. Residents may vary their response to the effects of different opioids. Therefore, always check and provide ongoing pain assessment, which is essential after a conversion. Monitor the effectiveness of the new opioid and make sure the resident is able to tolerate it. Monitor the resident for opioid toxicity. Look at their responsiveness of the patient, pinpoint pupils, confusion and slowing of breathing. Monitor for any adverse effects like nausea and vomiting. Always include a bowel protocol. Opioids can cause constipation, so always monitor and give aperients. And finally, if the resident is becoming agitated, it's always useful to check that they don't have urinary retention or a full bladder or bowel. Take-home messages from this presentation. Always explore and believe the patient or resident. Utilize meticulous assessment processes. Make sure that they get analgesia regularly as prescribed. Ensure that there is something you can give them for incident or breakthrough pain. Always attempt to relieve pain and other symptoms. Assess, manage, evaluate, and assess again. And finally, don't be afraid to ask for help from the experts. Here we have a list of the references. Thank you very much for listening to this presentation.